Now you see it, now you treat it. Integration of imaging for routine PCI learnings from Light Lab. Something similar to the previous, but from the Western side of it. Over to you, sir.
Thanks, and I'll try to be brief to help catch up on time. I really appreciate the opportunity to be invited to this excellent conference. Can everyone see my slides okay?
Yeah.
Great, awesome. So I'm Kevin Croce. I work in Boston, Massachusetts. I think, it's not lost in this conference that there's 2 randomized trials that show that intravascular imaging guidance cuts MACE down by half in patients undergoing PCI. And I think there's been this is one of many meta-analyses which demonstrate that intravascular imaging lessens the occurrence of an outcome we really care about, which is cardiovascular death. And Gary's put together a slide I don't have on this deck, which just shows the mountain of trials that support intravascular imaging for PCI. And I think it's really, state of the art to how to do a PCI is to guide it with imaging. Additional to that, and Ziad talked a little bit about this in his presentation, in terms of our striving to be as good as CABG or maybe someday better, the Syntax study, unfortunately, was single-arm, but it looked at things like modern image guidance, new stents, physiologic assessment, and dedicated CTO sensors. And if you take Syntax 2 and look retrospectively at a very similar patient cohort to what was treated in Syntax 1, you see that the patient outcomes are excellent with PCI when it's done in a modern image-guided way, such that the PCI patients start to look very much like the CABG patients. And so some part of doing a good job and competing with bypass surgery to get good outcomes for patients, especially complex patients, is to use intravascular imaging as part of our armamentarium of how to optimize PCI results. So with that in mind, this is last year's data on the use of intravascular imaging globally, with the United States being about 20%, Japan being very high, but a lot of variability across continents. And we got to thinking, what are the barriers to adoption? If you look at the data, it's clear that there's benefit, but why are people using it more? Complaints are there's not enough people trained to do it well, it takes too long, and potentially there's too much cost involved. And I would challenge each of these. But Light Lab, mlbmax, and our opportunity to make a consistent and prescriptive imaging pathway to do PCI was really meant to address the gaps in training. We wanted to make OCT very easy for patients. And so many of us got together about a year and a half ago, and with Ziad and some other colleagues, we came up with mlbmax at a conference room in Boston. And this is a slide which I borrow from Ziad quite often, but it shows our US interventional fellows and their self-reported competency for things you need to do modern, high-quality precision PCI. They don't feel confident very much in physiology, certainly not in IVUS, and definitely not in OCT. So with that in mind, we really wanted to move forward to try to make this simple and teachable. And mlbmax, which was presented a couple talks ago, was really the product of trying to come up with a prescriptive and very regimented way to approach PCI with OCT. And once this was built, we set out to test this in a study called Light Lab. And so what OCT guided PCI is meant to do is it's meant to lessen the occurrence of things that we know drive MACE in patients, which the highest MACE hazard is having a stent which is poorly expanded. Also, things like distal edge dissections are quite noxious from causing MACE in patients, and having bad inlet and outlet disease is a problem. And as Ziad went through how to do mlbmax, one of the ways we coach people to deal with distal and proximal reference narrowing is, when possible, to stent normal to normal if the artery is amenable to that. So this is the application of mlbmax to try to lessen the incidence of things that we know drive poor outcomes in PCI patients. So mlbmax and Light Lab was a study which was done in 14 hospitals with over 40 investigators. It was meant to look at the prescriptive use of OCT in an mlbmax guided way. And this is a real world population, much like iOptico, with upwards of 55% of the patients having type C lesions. And this is a multi-phase study looking at decision making, later efficiency, and later application to complex PCI, which I'll talk about later because that data is currently being amassed. But effectively, even in the initial phase of Light Lab, this is real world, and the large number of patients had type C lesions, and long lesions in complex PCI were very much a part of the patients being treated in these centers. And so much like iOptico, if you look at the difference between angiogram guidance, where we had to call out and define our plan based on the angiogram, versus using the OCT data to assess how the OCT changed our decision, we see that the majority of impact was in the pre-PCI OCT, where it changed decision-making and diagnosis of things like lesion type, what we do for vessel prep, how we're going to treat, and number of stents. And this is the difference between planning a case by imaging or just endorsing it. If you plan the case because you paid for the catheter anyway, and knowing exactly what you need to do to optimally treat the artery, on the back end, there's a lot less impact of the OCT because you've gotten it right up front. And the cumulative impact across the pre and post part of the case is 88%, with the majority coming early. And so it's a difference between an image-guided versus an image-endorsed PCI. And I'll show you a little bit of data on the difference between those in a few slides. So with that in mind, morphology really is what changes our decision-making. As you look at morphology, it had the greatest impact on both the pre-PCI planning and on the post-PCI, with impacting things like what we're going to do for vessel prep and how we're going to address an important indicator of MACE, such as underexpansion. Additional to that, our assessment of lesions changed 22% of the time, where it got upregulated and we increased in severity. So to the point made earlier in one of the wonderful talks that was given a few minutes ago, an angiogram is a terrible way to determine the calcium burden. And that point has been shown in live cases over the course of today and in the presentation, which was beautifully outlined by one of my colleagues a few minutes ago. So with that in mind, when the OCT detected calcium and the angiogram didn't, it led to a 47% change in the vessel preparation strategy, with escalation to more aggressive predilation, or in many cases to atherectomy or laser. This is where the case is either won or lost from an ease of stent expansion standpoint. And if you think about the change in terms of diameter, people are as likely to oversize based on the angiogram as they are to undersize. And so we saw really a bell curve in terms of how the OCT informed the choice of stent size. Additional to that, if you use mlbmax, about 80% stent expansion is achieved on average after the stent is placed, post-dilated, and the post-PC optimization is done. In cases where the OCT showed there was underexpansion, in a large number of cases, the investigators went on to do additional post-PC optimization. The goal is getting the stent to at least 80% expanded, as Ziad outlined, but preferably to 90% expanded relative to the reference segment on either end of the stent. And so if you think about the effect of PCI planning with OCT on de novo lesions, there is several hundred OCT cases with in-stent restenosis in light lab. And this is something which I'm very passionate about because we have a pretty busy stent failure referral practice. If you look at the impact across pre and post-PCI OCT planning for de novo lesions, it has an even larger impact when you go ahead and look at in-stent restenosis cases. Now, I'll be interested to see, Ronnie, if you can show very similar overlap in your curves, if you get a chance to look at this with your core lab. Some of the nice congruency and agreement between our two studies, which are done independent by people that didn't know each other, has been one of the more fun things of my involvement in this project. So I congratulate you and your co-investigators. It's nice to see that we agree quite easily, despite the fact that we're several thousand miles away from one another. If you look at the later phases of OCT, as people went from the baseline phase of early assessment and then into a little bit more practice with about 20 or 40 cases in each phase, we see that the application of OCT to type C lesions grows with a little bit of experience. And so this I take as an underscored exclamation point that once you get a little bit of experience under your belt, this technology is more than ready for real world practice, as we showed even in the early phases of light lab, where it was being done at 12 centers with 40 different operators. Additional to that, with a little bit of practice, the percentage of times when you can't get usable information from the OCT goes down substantially. But even for people that are early on in their learning experience, most of the time, with a little bit of coaching and a little bit of attention to the OCT run, you can get high quality and usable OCT images the vast majority of the time. And the chances that you can't use the information goes down to less than 3% after you've had a little bit of practice. Additional to that, with time and experience, after about 20 to 40 cases, the time spent in light lab actually doing the OCT decreases. And this goes back to what Ziad showed earlier with the LED OCT guided PCI that he showed in that test example. is it only adds about 10 minutes total to the case to come out with a precision PCI guided result where you know that you've done everything possible to keep your patient from having a stent failure and coming back with a stent that's no longer open. Additional to that, and this is one of the more cool things which has come out of our recent analysis, in cases where just a post-PCI OCT was done, mlbmax was not used, the case was not planned based on the OCT. They just checked their work when they were done. Versus actually using the entire pre-PCI planning OCT workflow and then the post-PCI optimization, you actually use less contrast when you get it right up front by planning the case with OCT, as was demonstrated by the mlbmax strategy that Ziad outlined. And so it's a really nice way to show the value of knowing what you're getting into and actually rationally planning the case as opposed to just checking on the back end, where you've often gotten it wrong and end up using more time, more dye, and it's more work to fix it on the back end. So with that in mind, the key takeaways are that when the full range of pre-PCI planning and post-PCI planning imaging is used, we have a major impact on the strategy with less impact on the optimization, because you've gotten it right up front in terms of having a well-placed stent, a lesion that's modified appropriately to accept that stent and have it expand well, and then landing normal to normal and working on apposition expansion and sizing. So with that in mind, by way of summary, intravascular imaging improves PCI outcomes and likely saves lives. Intravascular imaging is currently underutilized, and mlbmax was built in response to that to bring consistency, ease of use, and a very simple and algorithmic approach to doing this. An algorithmic application of OCT imaging improves procedural decision-making, facilitates optimal stent deployment, and you can do it on 2 different continents and get the same results. I really appreciate the invite today. Thanks for having me here.